Hello everyone, today we are in the setting of the chemotherapy course 2025. It's the 40th edition, so an important date. I'm fortunate today to welcome Thierry Petit, who comes to us from Strasbourg. Professor Thierry Petit is a breast cancer specialist, and we will talk a little bit about what's new today. And I think what's new is probably what we heard in San Antonio, which means the few important trials in local regional treatment. In particular, I would like you to tell me your opinion on this study of women elderly with breast cancer, whose goal was to determine whether to operate on these patients or from the outset, or wait until they progress under hormone therapy before operating on them.
Yes, of course. This year there have been many studies on regional local treatments that will probably change practices and the study you're talking about. So these were elderly patients over 70 years old with Rh positive and HER2 negative tumors. And it's true that in practice, in the tumor board meetings, when we discuss these patients, there is always a strategy that can easily be considered, which is hormone therapy. We will see what happens with hormone therapy.
And so, in fact, we have data here to show that surgery is important. So it's data from a meta-analysis of 3 studies asking this question: is it good to operate on them right away? Rather give hormone therapy, which in these studies was tamoxifen, and operate if it is observed that the hormone therapy no longer controls the disease. This meta-analysis showed a benefit in overall survival, well, in specific survival, and in overall survival for the patients who were operated on immediately.
I believe this is quite important information that can potentially be put into practice immediately, the following day in our multidisciplinary meetings if the patient is operable. He needs surgery because it improves overall survival.
The discussion still, we talked about the benefits of hormone therapy lasting a few months, which allowed for the patient to get used to the idea that she was going to have surgery, for the oncologist to determine if our anti-hormonal treatment was effective with a reduction in volume. And is that something you usually do?
That's certainly an option, but it wasn't really, in the study, it was surgery at progression. Obviously giving a neoadjuvant hormone therapy and assessing the response to hormone therapy over a short period of a few months remains an option, of course. And then, as you said, it allows the patient to prepare for this surgery and to enter the surgical team's operative program, possibly preparing her if necessary. So we are on these treatments, on these studies about local regional treatments. There have been studies on radiotherapy, we just talked about it, and notably a randomized study, I think, that focused on the interest of radiotherapy of the chest wall after mastectomy for T1, T2, N1, or T3, N0 tumors. Can you tell us about it, Mark?
Study. It's really interesting because in France, we usually irradiate the chest wall after mastectomy. This study involves patients who do not all have a very good prognosis, as there are patients who are N positive. Well, we did a comparison, a randomized study on 1,680 patients. So chest wall radiotherapy versus observation with the usual adjuvant treatment. And we realized that there is no difference in terms of overall survival with a follow-up of 10 years. So certainly there is a little bit more local recurrence on the chest wall and in the axilla, but this difference is not significant. It would mean that we could probably adopt the approach of no longer systematically irradiating the chest wall of these patients. And in particular, I am thinking of those with lymph node involvement where we do it systematically.
Yes, of course. Will it change practices quickly?
Excellent question. Will it change practices? I think we need to change our discussions with our radiotherapist friends before including this approach in our multidisciplinary consultation meetings. But I think it is a gain for patients because radiotherapy can cause a bit of radiotherapy, a little local burn, and then it's also a financial gain. Avoiding radiotherapy still concerns a significant number of patients.
So if we go a little further into local regional treatments, I think we need to talk about this very fine study, which is a study conducted by a German and Austrian team, and it is a randomized study. Absence of sentinel lymph nodes on a patient who had no palpable lymph nodes clinically or seen with imaging. Of course, so the de-escalation at the lymph node surgical gesture level continues. So it was an INSEMA study, about 5,000 patients included, and the patients included were T1 to T2 and 0, clinically in the initial assessment. The lymph node gesture was not systematic. There was a randomization between sentinel node biopsy or no sentinel node exploration. And in fact, in the end, there is no difference in relapse-free survival and overall survival between these two situations. That is to say, the sentinel node or no sentinel node procedure. De-escalation continues. So when we look more closely at the type of patients included in the study, it was still very predominantly T, one more than 90%, and mostly low aggressive tumors. There were very few grade 3, of course, so the doctors had selected the patients.
Rather good prognosis, therefore, indeed, for a patient with an initial T1N0 tumor without adverse histological factors, indeed manifestly, we can now do without a lymph node procedure. The conclusion, I believe, of the speaker was this practice should be reserved for patients over 40 years old, Rh positive, grade 1, grade 2, HER2 0.
HER2 negative, negative, but that can change a lot in our practice because the number of patients is considerable. So, of course, and this should completely transform our practices quite quickly. Again, we will discuss it in the multidisciplinary team meeting with our surgical colleagues. Even though they were good patients, if I remember correctly, there is still a 10% relapse rate over 5 years in both groups. But still, this is not a population with excellent prognosis. Relapse of 10% at 5 years.
Yes, of course. Yes, you are right. So once again, we are also waiting for more perspective perhaps on the events, of course.
But it's true that I think it's the study that impressed us the most.
Yes, more of
the de-escalation continues. So obviously it's always the question, we can't de-escalate everything at once.
We cannot de-escalate radiotherapy, de-escalate the surgical procedure, potentially de-escalate chemotherapy indications. So there is also a problem of overall management coherence when the three therapeutic acts occur: surgery, radiotherapy, and medical treatments. So another study on local treatments and surgical treatments. This is the situation of a patient who has been transferred. A patient who was treated for breast cancer is known to have a mutation. She develops this breast cancer due to this predisposition to the BRCA1 or BRCA2 mutation. The study evaluated the interest of prophylactic surgery in patients under 40 who have already been treated for a first breast cancer. Can you give us some insights?
It's a cohort study focusing on approximately 5,000 patients. Some have undergone prophylactic mastectomy on the side. Opposed. Others had ovarian removal and others had both treatments. It is an extremely interesting study because until last year it was said that maybe one should not systematically propose doing a prophylactic mastectomy because probably there were slightly more relapses when a prophylactic mastectomy was not done. But we were not playing with global survival, and there this study shows it's a cohort study, not a randomized study. However, it seems that doing a prophylactic mastectomy on the opposite side will affect relapse-free survival, but especially overall survival. And the hazard ratio is 0.65% when performing a prophylactic mastectomy on the opposite side. So that's the first element. The second element is, what is the effectiveness of ovarian suppression? Well, on this risk of ovarian tumors, and 2, at the level of the contralateral breast. And there, similarly, we are very pleasantly surprised to see that it will play a lot with a hazard ratio of 0.58. So practically 60, 0.58. That's 40% of patients who will not, or see breast cancer appear on the opposite side. So there, I think we absolutely need to change our practices. I was sometimes hesitant to do the prophylactic mastectomy. I'm not hesitant. It's important to know that this study, it was done in particular for ovarian suppression at an age that was 39.7 years, if I remember correctly. So about the age at which we propose ovarian suppression, 41 years for those with the BRCA1 gene, and 42 to 43 years for those with the BRCA2 gene. We are in this context, and I think, yes, we absolutely need to do our ovarian suppression, but now we need to systematically add a prophylactic mastectomy on the operative side. A small caveat, though, is that all these patients had breast cancer before. There remain the patients with BRCA1, BRCA1-2 mutations who haven't had cancer yet. And there, we have no answer. So I think we should not rush into performing a prophylactic mastectomy on a young woman who is mutated but does not have cancer. And we should probably still focus on close monitoring for these young women. In summary, briefly, if we look a little at these loco-regional studies, what do we take away? It is the older woman.
In the elderly woman, this question of immediate surgery or hormone therapy and surgery at the time of progression. Here are the graphs, as I told you, the strategy where we perform immediate surgery and statistically higher in recurrence and mortality due to breast cancer. Therefore, the preferred strategy for a patient over 70 years old is primary surgery.
Regarding the Supremo trial, as you will see on this slide, there is no benefit in doing radiotherapy on the chest wall compared to observation in patients who are either T1, T2, N1, or T3, N0. Thierry, now the INSEMA trial, one of the most impressive studies we have seen, show us the graphs.
So interest in a sentinel lymph node or the absence of surgery at the lymph node level. It's 5,000 enrolled patients, primarily T1N0 with good prognosis, hormone receptor positive, low grade. There is no difference in survival without invasive disease, with a strategy, without axillary lymph node exploration. Overall survival is also the same.
For the study of patients with mutations who undergo preventive mastectomy, cohort study, and ovarian suppression, I will show you the two important slides, which are the hazard ratio when performing prophylactic mastectomy at 0.65. You see the curve. The second slide is about ovarian suppression. You see with a hazard ratio of 0.58.
Thank you very much for following us during this debate. And if you want to know more about cancer treatments, feel free to come and watch these courses on the platform coursdechimio.com. Thank you and see you soon.